Okay, welcome everyone, and thank you for joining us today on a beautiful Thursday afternoon here in Little Rock. Today's webinar, Hand in Hand, Building a Trauma-Informed System of Care. So we're going to be discussing a little bit about what RBEST has been doing throughout the state with some different groups regarding trauma-informed care. And again, before I turn this over to our presenter today, I'm just going to go over a few housekeeping items. And if you need to ask a question during the presentation, please use the chat feature, which is found on the right side of your screen. And just a reminder that this webinar is being recorded. We will provide a link to this presentation from our website. I'm going to go ahead and turn it over to our presenter.
Well, hello, everyone. There's a few of you out there. I see Beth's on, Carrie, and Rhonda, so it's nice to have you all here. We might have a few others joining us as we go along. This is not going to be a long webinar, but I really wanted to make sure that I let you all know some of the things that we're doing across the state beyond the mental health initiative that we currently are involved in. And, you know, we've been doing these different types of presentations to all different groups. And a couple of months ago, I was presenting to some of the individuals who work with the courts, like prosecutors, judges, CASA people. And somebody said to me, well, have you done this presentation with your mental health professionals? And I thought, you know, we haven't done that, and it probably makes a lot of sense that you all need to know what other folks are learning beyond the TFCBT. So that's why I thought, Chad, let's schedule a webinar. And for those that are interested, we can kind of go through that quickly just so you all have a sense of that. And I think one of the important questions for you all to be thinking about as we go through this is what do you think is important to communicate to the professionals that you work with outside of mental health? So we're basically talking about DCFS, prosecutors, judges, other social workers who might be involved in the school or teachers in the educational system. So just to be thinking about that piece of it, because we need that communication to go two different ways. So the goal of our trauma-informed trainings across the state, we really have 4 of them. And the first is we really want to protect children from additional trauma as they enter and progress through various systems. We know from research and then from our own kind of clinical knowledge that we've gained over the years is that children sometimes enter into foster care and they experience abuse again. There's a very large number of children who enter into DYS in the juvenile justice facilities, and they are re-traumatized. We know that kids are bullied at school. So we have children who have already been exposed to trauma, whether that's in the home or in their community, who then are removed from the home, or there's something that happens that kind of activates one of the systems, and then unfortunately they are re-traumatized. And that's the most important thing, is to make sure that these children are not re-traumatized. And that's why we go out and we talk to these individuals about the importance of having a trauma-informed system of care. The second goal is to provide a common language across systems. So basically, when you talk about an assessment, the child welfare worker has a good sense of what you're talking about. And when they talk about assessment, you have a really good idea about what they're talking about. It may not be the same thing. For example, your assessment may be the UCLA PTSD scale, but their assessment is called the Family Strengths and Needs Assessment, and it basically looks at a number of issues, including risk factors in the past and risk factors in the future, family history, other issues that are related to the current abuse that may impact their overall treatment planning and decisions. Third, we want to obviously promote continuity of care, planning, and collaboration. So really just so everybody kind of has a sense of what needs to happen with these children and are working together in a collaborative way to make that happen. And finally, really important for all of you is to prevent secondary traumatization in professionals. So we do talk about that in each of the presentations that we do. So those are really the 4 goals of the trauma-informed system of care across all the different disciplines that work with these children. Now, these are, as I think you probably are well aware, there's probably 12 to 15 different systems that are involved when a child reports some type of abuse. And we've kind of focused on some of those in terms of doing trainings and various kinds of workshops and outreach. Specifically, obviously, we've done mental health through the TFCBT trainings, through the peer review, through the ongoing consultation calls, and other types of things like webinars. Obviously, we're working with child advocacy centers over the years. We have done quite a bit with judges and CASA, not as much with the prosecutors, so that's an area that really needs some development. We have done trainings with the Division of Child and Family Services. We started out with the directors, and then we did as many frontline workers across the state as we possibly could, and in all the different regions. And then we've also been doing a Lunch and Learn series with them to kind of provide booster sessions around some of the trauma issues that we've been teaching. We have initiated trainings in the Division of Youth Services to let them know a little bit about how to create a trauma-informed system of care, including assessment and evidence-based interventions. We have done some outreach with foster families, but I think that's another area where we can really grow. We've also identified 3 other areas that I think we can probably move into. One is educators, and we've kind of established an initial relationship with the Director of School-Based Services for the Department of Education here in Arkansas. Medical professionals, primarily primary care physicians and pediatricians. While they may not be the person that's doing the evaluation, they may be someone who knows of a child who's been abused, or they have actually had to report that, so we're going to try and reach out to them a little bit more. And then eventually we hope law enforcement, although we hope that our MDTs and our child advocacy centers are doing a really good job of that as well. So I'm going to briefly go over the trauma-informed principles. Many of these principles will be very familiar to you, but what I'm going to do is kind of present it in the way that I talk about it with these other professionals who don't really have the expertise in mental health. I'm not going to go through each of these individually on this list because I'm going to go through them individually in a moment. So these are kind of the general principles, and they change just a little bit as you go across different disciplines. So what we may focus on for DCFS workers will be a little bit different than what we might focus on for court personnel. But these are the 9 basic principles. So what we do when we do a trauma-informed training is we go out and first we provide a pretty comprehensive trauma overview. We talk about the definition of trauma, including acute, chronic, and complex trauma. We describe the prevalence of trauma, and we kind of address a number of different traumas, not just child abuse, but some of the other types of acute traumas that a child might be exposed to. We go into a lot of description of the short-term and long-term effects of trauma, not only including, the emotional, psychological, social effects, but we also go into some biological effects, including some of the brain changes that occur as a result of trauma. So what we're really trying to do is to address with these professionals, they can get kind of tunnel vision and see, like, this is my job and this is the part of the job that I need to do, but not always take into consideration what the long-term impact of this trauma could be on this child. So we really make sure that we address all of that so they have a more of a sense of purpose of what they're doing to help this child and get them into recovery. And then we also discuss the aspects of the complex trauma, which is really what most of you deal with from a mental health perspective, is when you have a child who's had chronic abuse and a lot of relationship changes, and been located, into a new neighborhood or new family or new school, all the effects that might have on that child. So we really make sure that they have a pretty in-depth view of trauma and its effects, and that then kind of helps them understand how to deal with that a little bit more effectively. So as I mentioned, the first goal of the trauma-informed care is to maximize safety. And, children often experience traumas in other settings, and we really make sure that that's reiterated again and again so that we're not traumatizing these children once they've been taken out of the home or put into the juvenile justice system. We stress that psychological safety is as important as physical safety. So, for example, law enforcement and DCFS, a lot of times they're very concerned about physical safety, assessing whether or not the home is safe or the family is safe for them to remain. But they tend to ignore or forget about the psychological safety. So we really stress that from a mental health perspective. We also talk a lot about how children are exposed to trauma can engage in challenging and even risky behaviors. And we all know this from the mental health perspective, that there is increased rates of suicidal ideation, self-cutting, substance abuse, unprotected sexual intercourse. And these are the kinds of things that we really need to watch out for long term. And particularly when you're in systems like DYS, juvenile justice, those are the kinds of things that they are familiar with, but they may not always attach that to an early trauma history. So that's what we try to really teach them, is that a lot of these acting out behaviors may not be because this is a bad kid, so to speak. Rather, they have had a series of traumatic exposures, and that may actually be affecting them as a reaction of the PTSD. We also talk about the importance of managing emotions. And again, we help them understand the effects of trauma and the importance of teaching coping skills. What we hope this does is it helps bridge the gap between a child entering the system and then the professionals who have contact with them recognizing the need to get this child into treatment. But we also try to encourage the frontline workers to work with the child to manage emotions, not trying to be a therapist, but just helping them to monitor their emotions a little bit and talk to them, allow them to, talk about what's going on with them in circumstances without having so that they understand that if a child is acting out, sometimes there has been a trigger for that child. And it's not that the child is testing them, so to speak, which it often seems like, but that they are trying to understand their world. They're trying to gain mastery over something that they have not previously had control over, and helps them to vent some of their frustration. And by doing so, we hope, for example, in DYS or DCFS, when there is a child who is having behavioral problems, that the solution is not to restrain or seclude or remove from the home, but rather to really understand what's going on with that child and the triggers that have occurred for that child, kind of recognizing patterns. We also talk about how therapists can make new meaning of the trauma, and for all of you, the TFCBT obviously is an important part of that. But we also know that making new meaning can occur in the relationship between that professional and the child. So first of all, we encourage all of these professionals to provide some psychoeducation to the child and to the parent. Things like, this has happened to other children that I know. You are not alone. These kinds of things do happen. We think you're really brave for what you have been able to do thus far, and we really admire what you've been able to do in terms of telling and talking about it and answering questions in a really brave way. So we try to give them that sense that whatever they say to the child is really important in terms of their road to recovery. We also provide them opportunities to discuss their thoughts and feelings. So a lot of the frontline workers, when we went out and we did the trainings, they were like, well, I don't know. I've got a lot of stuff I need to take care of, paperwork and so forth, and I don't know if I have time to talk to the child about what's happened and what's going on and how they feel about everything. And we try to make suggestions that are very simple for people to be able to put into practice. So one of the things we tell them is we say, start measuring their stress reaction to different things. So we say, as a suggestion, if you were kind of measuring your fear on a scale of 1 to 10 or 1 to 100, with 100 being the worst thing you've ever experienced and 1 being I'm calm, I'm totally fine, what's happened in your life that might be a 10 or a 100, and what's happened in your life that might be a 1? And what we hope that will do is it will kind of calibrate for the child their scale of fear. And then when things happen in the future, for example, the child goes on visitation or the child has contact with a sibling that may have offended on them, they can actually start talking about what their fear level is. And they'll get, children kind of pick up on those kinds of things and can kind of make a game out of it. And it's just a way for the child to have permission to be able to start talking about things, but for the social worker or the law enforcement officer or anyone else that's working with the child to not feel like it has to be kind of a therapeutic intervention, but just a way of starting the conversation. We also encourage all of them to promote the positive in a child. So first of all, with regard to the trauma, so that the child has a sense that whatever has happened, they've been very brave or courageous to talk about it, that they're doing a good job of answering questions, that they did what they could at the time in order to survive, and now they're progressing and doing something different. And then beyond the trauma, because we really want all of these professionals to reinforce that the child has a sense of self beyond what's happened in the trauma. So being able to reinforce, you like to play ball? Really? Oh, that's great. What position do you like? And how long have you been playing ball? Or, oh, you're interested in playing a musical instrument? What's your favorite? Or what band do you like? So being able to kind of just talk to the child in a very normal, day-to-day kind of way, instead of focusing completely on documentation, paperwork, and getting all the questions answered for the trauma. Then we also talk about therapeutic interventions, and we explain TFCBT and some of the principles of TFCBT and what you as the therapist are working on with the prac skills and then the trauma narrative. So we make sure that they have a really good sense of how a child starts out making new meaning and then how that can happen with their assistance as well as the intervention of a mental health professional. We also encourage them to address the impact of the trauma, including the secondary aspects that often affect them, including leaving school, leaving their friends, having to establish new relationships, health-related problems that may come up as a result, difficulties even in school because they're having trouble paying attention, and really encouraging them to understand the child in the context of their environment and acknowledging the impact of that trauma. So it's not, okay, here's the trauma, this is what happened, now we're going to move on. We want them to really the professional really help that child realize, yeah, there have been a lot of changes in your life, a lot of things that have happened, and we want to kind of help you integrate that, and all the different people that are going to be working with you are going to help you be able to start that recovery. Obviously, coordinating services, we can talk about this and talk about this, but I know from the stories that I've heard out there in the field, it doesn't always happen. People are very busy. People don't always have time to make phone calls to other professionals. When they do, those professionals don't always call them back. So what I really try to encourage them is to think about what it feels like to be on that end of things when people don't call you back, you can't get the information you need, you can't really figure out what to do next with this child, and to then try to improve what they do. So it's just basically figuring out how to coordinate among all the different systems. As I've mentioned before, when a child reports some type of abuse, there's usually about a dozen different agencies or systems that get involved in their lives. And each one has a different role, but it's important that they all communicate with each other. A lot of times the mental health professional and the DCFS frontline worker are the two anchors for that. They're usually the folks that the communication goes through most directly. And it can be pretty frustrating for all the other folks that aren't involved, or it can be pretty frustrating for DCFS and the mental health professional if they're not talking either. So we understand on both sides how that can get tangled up, and so that's one of the things that we really work hard to get them to see the importance of that. We also try to encourage folks to develop a framework for documenting the trauma history, exchanging information, coordinating assessments, planning and delivering care. So, for example, I tell the DCFS workers that the mental health professionals, we encourage the mental health professionals to administer the UCLA PTSD scale. And they get very excited about that. They're like, well, I've never seen that. That would be really great if we could have access to that. We also talk about the fact that Medicaid requires, and I'm blanking on the questionnaire name that everybody has to fill out. I'm so sorry. The YOQ, thank you. The YOQ. And the DCFS workers are like, I've never heard of that. What are you talking about? So there's a lot of confusion about what are the appropriate assessments and what's actually happening on the mental health side. And I am sure if we spent the time talking about it, we could hear from your perspective, you probably never heard of an FSNRA. So one of the things we do is we really encourage all the professionals to share what they have about this child. We realize that there are confidentiality issues. I think those can be resolved easily if folks are talking to each other. So planning and delivering care, figuring out what's in the best interest of this child, whether the primary caregiver needs to be attending the therapy sessions, when's visitation going to occur so that the therapist is aware of that coming up and can kind of deal with that with the child, help them with coping skills, and then follow up afterwards. So just figuring out how to talk to one another and how to do that more easily. The next one is assessment, and we talk about the importance of doing the assessment basically to understand what's happened with the child, but also to identify risks for future trauma. And so, really assessing their safety, their ability to, if they're removed from the home, to be able to talk about any further abuse that might occur, to identify potential risk behaviors such as running away, danger to self, danger to others. And we talk about those risk factors just as we would a mental health professional. And to be able to do those assessments and then obviously figure out whether or not there's a need for a mental health referral and following through on that mental health referral. I think all of that provides really valuable information for case planning and treatment planning. But again, it requires communication among all professionals for that to be able to happen. The next kind of principle of trauma-informed care is to promote relationships for this child. About 500 children were placed in 10 or more settings in 1 year in Arkansas for the last year that we had data for. I think that was about 2006, 2007. 500 children, 10 or more placements in 1 year. You can see that the importance of promoting various relationships that kind of anchor that child and provide some important attachments for them is critical with those children. And obviously there are more children that don't have near as many placements but still have multiple placements. So they may be separated from not just their biological parents, but their siblings, extended family. They may be separated from their teachers, ministers, Sunday school teachers, their coaches, everybody who's really important in that child's life. And as we know, that attachment is so significant for their psychological, cognitive, social development. So when we remove them from the home, we are taking all of that away, and it's important for us to help establish new relationships for these children, so interacting with the school, so the teachers have an awareness that this child has moved from somewhere else and has been basically isolated from almost everyone they know. As a mental health professional, you're very aware of the effects that those attachments have on those children. But not all professionals have been trained in that way, and that's what we really try to encourage them to think about a little bit more, and how do they then kind of place that child into environments that are nurturing and are helpful for them. We also encourage these professionals to support the family, and that's sometimes the most challenging task because they're dealing with families where the abuse might have occurred, or where the mother does not believe the child, or where there's been some significant neglect. At the same time, in many circumstances, reunification is the goal. So we have to figure out how we can begin to educate parents and encourage them, motivate them to begin to enter treatment, to begin to their own recovery. We have really strongly encouraged DCFS to focus on maternal history of abuse and whatever adverse experiences they've been exposed to, because we know that that will affect their parenting, it affects their mental health, it affects the potential for their substance abuse. And so by doing so, what we hope is that it enhances the empathy that the DCFS worker has for that particular parent and enables them to work a little bit more collaboratively with them. We know that support from caregivers is a key factor influencing a child's recovery, and we want all of the professionals to really work with the parent so they understand that. When you start addressing that with the parent, the hope is that they will be more inclined to enter into treatment and begin to support their child a little bit more fully. And if you have many professionals who are saying the same message, we hope that that will really increase the likelihood that that parent will follow through and engage in treatment. And finally, we really encourage everyone to manage their personal stress. And we actually do exercises in the classroom in order to help them learn some coping skills. And we basically use the practice skills that all of you have focused on with TFCBT. The wonderful thing about that is that they can reinforce that with the child. So we really go into the breathing. And I say to them, you know, when you're with a child and you're driving and they're in the back seat of the car, or when you're sitting in an office with the child and you're waiting on the doctor, or you're waiting for the, you know, prosecutor or whoever, you can practice breathing with that child. If you know how to do the breathing, you practice it and you both do the breathing together. And what it does is it reinforces what you all are out there doing, what you're teaching them to do, and it helps all the professionals manage their own personal stress as well. So that's one of the things we teach them about the breathing. We also teach them about, you know, meditation and prayer and everything that can be very helpful in the setting of stress. So high-risk professionals are confronted with danger, threats, violence. You know, this is true for law enforcement. It's true for DCFS. They're out there on the front line. I have made calls out to Alexander, the facility for CYS for kids with behavioral disorders, and every time I call out there, there is some type of traumatic event that's happening. You can hear it in the background, and I think, oh my gosh, these workers are exposed to this stuff every single time I call, and I bet it's happening every day. So in that, it's important for us to manage our personal stress so that we're not getting burnt out, number one. And in doing so, we also can empathize with children's helplessness, their anger, their fear. If we get in touch with the amount of stress that we're under, I think we can also have more empathy towards these children and maybe these families. Sometimes if professionals are parents, they have young children, particularly young children who are the same age as those with whom they're working, it can increase their stress even more. So I actually point that out to them so they can be aware of it and understand it when it does happen. And then we talk about the symptoms of secondary traumatic stress and say that that's not precipitated by the workload, such as paperwork or, having a boss that's just not very understanding or having peers that don't support you, but it's actually as a result of being exposed to specific stressors while on the job. And the new DSM-5 category of PTSD now includes that you don't have to actually experience or actually witness a traumatic event. You can be exposed to it by hearing stories. So all of us, whether we're mental health professionals, DCFS, police, that is actually now documented that contributes to PTSD, is hearing those stories over and over again. So it's nice to have that kind of confirmed for all of us. So ways to manage personal stress, and we were very clear about this with many of the directors when we met with them for DCFS, that workers need to have regular supervision and supportive consultation. We hope that you all are getting that when you go through your consultation calls and or your peer review calls. We also hope that you're getting it from your own peers and your own agencies. It's really important that you have that when you're working in this kind of a stressful environment with the kinds of accounts that we are exposed to. Considering therapy for unresolved trauma, if that applies to you. Practice stress management through various forms of relaxation, prayer, deep breathing, and even exercise. And then one of the things that we have done with DCFS in particular is develop a written plan on how to focus on obtaining a more work-life balance. And we got some really great things from them. We also followed up with them to see if they were doing it. Some of them were, some of them weren't. But I think if we continue to reiterate the importance of doing this, it will be important for them over time. The other issue that we know we're running into is that there is a lot of transition in DCFS as well as some of these other professions. So, we can do a training one year, and the next year 50% of those people have left the field. So we have to keep doing it again and again. And that's been a challenge for us, but we're working on it. So the question is, I guess, what can you do as a mental health professional to kind of help us establish this trauma-informed system of care? Many of you you're already doing it. You've learned the TFCBT, you're practicing the TFCBT, you're seeing these children, you're working closely with the child advocacy centers, or you are in a child advocacy center. But there are some other things that we think would be really helpful. Number one, communicating with other professionals involved in a specific child's life. So as much as possible, trying to reach out to that DCFS worker. And trying to stay in contact with the director that's in your particular region. If you can invite them to your agency one time just for a meeting, just so they have a sense of who you are, that you're doing trauma-focused therapy, and that they do have a little bit more continuity than some of the frontline workers. But just getting acquainted with some of these folks. Also being involved in MDT, because we know that those are the ones that, A lot of times those are the representatives of those particular agencies in the area, and just starting a way of communicating with them would be a positive way of creating that collaboration. We would love for you to do some education or training in your region. If there are folks out there that want to do some presentations, please let us know. We can set that up for you. We can put the presentation together for you. We can put all your notes together for you, and we can say, okay, now go out and talk to your local DCFS office, or go do a talk for MDT, or go do something with Kiwanis Club. Go out and do as much outreach as you can, because that helps us continue this effort to create awareness of trauma and its effects and how best to address the needs of these children. Most importantly, and that's my little Buddha baby down there in the bottom of the slide, take care of yourself. Physically, emotionally, socially, recreationally, different ways to manage your stress, because we don't want to lose you. We want to have you in this field. You're all great contributors, and we appreciate what you're doing, and we don't want you to burn out, and we don't want you to leave the field. You are well-trained. The experience that you have is so important to these children, and so we want you to take care of yourself. And so that's what I tell everybody when I do that talk, is that that's one of the most important things, because if you don't take care of you, you can't take care of anybody else around you. Those are kind of our basics for trauma-informed systems of care, and this is just a summary slide of the goals: to protect children from additional trauma, create that common language, promote the continuity of care, and finally, prevent secondary traumatization in all of you. So, questions? Tad, can we take that out of lecture mode?
Yeah.
The conference is no longer in lecture mode.
Okay, if you have a question, you can speak up right now and ask, or you can use the chat feature and we'll answer those. So,
anybody have any questions? Is there anything in particular that you all feel is important that I communicate when I get out there and talk to those professionals? Really? Okay. Well, if you all have things that you think would be important, just shoot me an email at a later time, or call Chad or shoot him an email, because we are constantly changing that training, and if we are not meeting the needs of different folks in the community, then we will change it. And so we've done that. We've been constantly modifying. And also, if any of you are interested in doing any talks, we'd love to hear from you. So if there are no questions, then we will sign off. I thank you all for being a part of this today, and I hope this was a helpful presentation.
Thank you very much.
Thank you.
Thank you.